Okay, so all of my sources today come from the Maitland vertebral manipulation and peripheral manipulation text, as well as the Chad Cook orthopedic text, and some from the Principles of Examination bonus chapters from Maitland, but I'm not sure which book. So we'll start with the lumbar versus hip differentiation, and I'll just demonstrate this with rotation like it's done in the Maitland vertebral text. So this is to see with your patient's concordant pain, whether it's coming from the lumbar spine or hip. So first things first, you'll have your patient have the cross arms over your chest and rotate towards, stay facing right, rotate towards the affected side, so towards the left as far as you can go. All right, so once he gets there, I'll have him go ahead and place his hands on my shoulders while I stabilize and shift all of your weight over to this left leg to where that right leg is just kind of bouncing on your toe. Okay, so he's turned all the way as far as he can to the left. Once he gets here, and I'm stabilizing here at the hips to make sure that they do not move, you take the left arm and put it on with your right hand and let your shoulders come with it and your hip. Perfect. So now he's de-rotated the lumbar spine, but I'm holding the hips in rotation. So if the pain is coming from the back, it should be slackened now versus hip pain would still be increased. Then to further accentuate this, if we haven't reproduced symptoms, I'll have him turn even farther with his shoulders to the right while I hold the hips here, which would only increase back pain if that was the case. All right, from there, again, this would increase hip pain as well. So this one would increase both. We've got very increased hip rotation and lumbar rotation. Now I will release the hips to match. So if it was hip pain, this should slack and now decrease. And if it's lumbar, it may come back on here as the spine rotates back with it. This can be repeated in any motion. So for example, we'll turn to the side. We could also do this with lumbar extension. So I'll say chest up to the ceiling, hands across your chest, and then take a step back with the left leg. So we've got lumbar extension and hip extension here. And while I stabilize, then I'll block here, the foot, as well as blocking the hips. And then just tip your shoulders forward. Perfect. So we were going to release the lumbar extension, but keep hip extension towards the back. So if it is coming from the lumbar spine, it should decrease while the hip pain should still be on. And then take a step forward. And now we've released hip as well. So you can do it in any range of motion, flexion, side bending, or a quadrant test, all the same way. The Maitland bonus chapter just basically says you reproduce the symptoms with range of motion, and then you increase or decrease stress at the different joints by stabilizing one and then slacking or tightening the other, and then reversing. So you can do this anywhere. Okay, and then you can step to the side till I'm gonna move this. So start by leg on your back. Okay, so now we'll look at primarily the active range of motion, and then of course from there we would do passive range of motion with overpressure, but it's a lot, so I will move quickly. Mostly pulling this from the Maitland peripheral text. So starting here, we'll start in supine because we can do a lot of these motions and then move into prone. So starting with very easy, the lumbar flexion. So I'll have the patient, so what we'll do with each of these motions in supine is actually have the patient place their hands underneath their low back. So we're gonna keep the lumbar spine in a little bit of an anterior tilt position, a little bit of lumbar extension. That way we don't bias the lumbar spine into flexion with these. So I'm gonna have you take your left knee and march it up towards your chest. So looking for 110 to 125 of active hip flexion. Obviously, if there's pain reproduced for any of these, or if there is limitations, like we see here, I would then have them come back down, relax, and I will repeat passively with overpressure to see if I can recreate pain. Of course, if there's tightness here, we'll look at joint capsule versus glute max. Is it pulling externally? Could then we have some TFL, tightness, things like that. While we're here, then I'll say, can you hold this position around 90 degrees of hip flexion? So then we'll look at internal and external range of motion. So start just by trying to move your foot out to the side there. So internal rotation, we're looking for 30 to 45 degrees here. Obviously measuring with the goniometer like we normally would. Very similar, relax, then I take him into passive, can add over pressure, and now move the opposite way. External rotation, got a lot more here, can do passive, can add over pressure. External rotation looking for 40 to 60 degrees. The key for this one is that, as we know, the piriformis switches from an external rotator to an internal rotator around 70 degrees of hip flexion. So obviously looking here at the piriformis for tightness, as well as looking at superior fibers of glute max and glute med, which act as internal rotators. Okay, so while we're also here, then we'll just have the leg straight, and then I'll just have you let it roll all the way out to the side. Okay, perfect. So if the knee flexes like that, the Maitland-Tex actually encourages you to look into, is the patient using more external rotation at the knee than they are at the hip functionally? So I would have him repeat that and try to keep the knee straight. And then measure for range of motion change to see functionally where are they getting their external rotation. And there we're looking again 30 to 45 degrees. Okay, now I'm going to come to the other side because we will do a abduction. So we've still got hands underneath the lumbar spine. I'm going to stabilize the opposite side, ASIS, so that I can make sure we limit any pelvic mobility with this, but we'll just take this leg and go straight out to the side. If I wasn't in this on video, I'll stand on the other side, stabilize, and I could give passive range of motion over pressure, come back in. Looking for 30 to 50 degrees here. Okay, and then a deduction, so slide towards me just a little bit. We keep this leg straight. So we'll get the opposite leg out of the way here. Again, stabilize here at the ASIS, and then you're going to pull this leg in as far as you can, and you're not letting anything happen at the pelvis. For this one, looking for 10 to 30 degrees range of motion as well. If it is tight, you might see TFL, you might see some glute there. With the abduction, obviously tightness with adductors. And then for the sake of time, while we're here, if we could not reproduce any of the patient's concordant pain with those tests, I might go into a combined motions test here. So with motions like Faber and Fader. So Fader, of course, being flexion, a deduction, and internal rotation, which we know would likely aggravate something like FAI and especially osteoarthritis, anything that has joint capsule implications. And then similarly, we can do Faber, flexion, abduction, external rotation, adding over pressure. Without the video, I would be giving counter pressure there so that we minimize any pelvic movement, which he just had. Again, implicated with capsular restrictions, osteoarthritis. So those would be our combined motions there. I'll have you go ahead and flip onto your stomach. While he does that, if I saw any limitations in flexion there, I might have him come into a quadruped position and re-measure hip flexion almost in a child's pose. Still looking for 110 to 125 degrees, but then you could kind of differentiate because that position allows for more posterior glide of the femur. So is that maybe something that's going on with hip flexion? And of course, are we getting more pain, less pain, that kind of thing. If we had difficulty with internal external rotation with 90 degrees flexion, I would repeat that in sitting. I won't do that on this video, we all know how. With a goniometer regularly, but I'll move on into prone. So first we'll do extension,